Good evening. My name is Amy. I'm a Community Education Coordinator for Boulder Community Health. I'd like to welcome you to our lecture on advances in cataract surgery. I'd like to go over the format for tonight's lecture. The lecture portion will last 40 to 45 minutes. Afterwards, we will use the remaining time for questions. Please type your short, general question in the chat box to the right of your screen, and we will do our best to get to it if time allows. Now, on behalf of Boulder Community Health, I'd like to introduce tonight's speaker, Dr. Kevin Cuevas. Dr. Cuevas is a fellowship-trained cornea specialist with expertise in cataract and refractive surgery. He has lectured locally and nationally on various aspects of intraocular surgery and has invented a novel intraocular lens to further advance the options available for the treatment of cataracts. Sincere welcome to Dr. Cuevas.
Amy, thank you very much for the introduction. I'm actually grateful to be here at this venue. I know it's a very popular venue for our Boulder community, and it's nice to be here. I have to say that I've not given a lot of lectures, but I've never given a lecture where there's no people other than the camera people and two others. So it's a little strange times, but thank you for carving out some time in your evening tonight. And the talk is called Advances in Cataract Surgery, and we're going to talk about a lot of things. I think it'll be very helpful in elucidating what cataracts are and cataract surgery, what goes on in cataract surgery, and then some of the newer technologies and some of my research, which I'm very excited about. A little bit about my education. I'm from California, from San Jose, Northern California. I went to college in San Diego, medical school at USC Keck School of Medicine. I did my internship at Emmanuel Hospital and Health Clinics in Portland, Oregon. Residency, UT Southwestern in Dallas, Parkland Memorial, residency in ophthalmology. And I did my cornea and refractive surgery fellowship at the University of Iowa in Iowa City. So traveled around quite a bit, but it was all very good. Before we start our lecture about cataract surgery, I think it's important to tip a hat to the inventor of the original IOL, intraocular lens, Sir Harold Ridley. Dr. Ridley was a British ophthalmologist. He practiced in the 30s, and I think he retired around sometime in the 70s. But he had the good fortune of seeing a lot of patients during World War II, particularly fighter pilots that had crashed their planes, and took care of these patients and learned that when the canopy of their plane exploded or during their crash, those patients that had a material called Perspex, which is plexiglass, seemed to do very well without a lot of inflammation in their eye, as compared to those patients who had glass pieces in their eye, who had lots of inflammation and multiple surgeries and did not do as well. And based on this observation, Dr. Ridley believed that he could invent an intraocular lens out of this material that would be biocompatible in the human eye. Prior to this point, cataract surgery was done through a large incision. The entire lens was essentially removed in one piece. No lens was available. No lens was put in the eye. The suture, the wound was sutured. The eye was closed. It was a 6-month recovery period. And when patients recovered, they had to get very, very thick Coke bottle glasses. They were extremely farsighted. Many of you have seen some of these elderly patients with those very, very heavy, very thick glasses. They were aphakic without a lens, and so they required these very thick aphakic spectacles. It was November 29th of 1949 that Dr. Ridley did his first surgery The picture on the right is an actual post-mortem. This is his first patient. Once that patient passed away, this is the original lens, the first lens that was implanted in the eye. The first implant in the United States was done around 1950, and that was slowly adopted in the years to come. There was a lot of criticism that Dr. Ridley had to deal with. Putting a piece of plastic in the eye was not thought to be something that was going to be good, and it turned out he was right, and that started the beginning of cataract surgery. This is the Spitfire, the British Spitfire that was used in World War II. You can see the canopy, which is made of this perspex or plexiglass material, and the pilots did have goggles, but they never wore them. I don't think you'll be able to really see it in this picture, but this pilot, of course, has his leather goggles on top of his head. They could just see better with those without the goggles. So what are cataracts? What is a cataract? What is cataract surgery? What is traditional versus the newer laser refractive cataract surgery? We're going to talk about femtosecond laser technology, and we're going to review the LenSx system, which is one of the 3 or 4 lasers that are available for surgeons to use in the United States. A little bit of anatomy. So a normal human lens focuses light rays. Those that are photographers understand the principle of optics and that a lens is needed to focus the image precisely on the camera film, the same as in the eye. What's interesting is that in the human eye, the lens, it's the cornea, actually, the tear corneal interface right here, that refracts 2/3 of the light rays. And then the lens, which sits behind the iris, behind your pupil, refracts 1/3. So the lens provides 1/3 of the refractive power of the eye. This image then is precisely focused on the retina for a nice clear image. In a cataract, as we age, the lens tends to become larger in size and more yellow or pacified in color, and the image is not able to be precisely focused on the retina and causes image blur. A little bit of lens anatomy. The human lens is made up of a number of different layers. I like to think about it like an onion. It has an onion skin-like membrane called the lens capsule, which is elastic and surrounds the entire lens. The inner portion of the lens is the harder portion, the first portion that is developed in the fetus. And then as we age, layers are added to the lens, and these outer layers are softer and called the cortical layers. What's very interesting, and this will be important later in the lecture, is that the lens fibers that are added to the lens as we get older are added in this one area here called the germinative zone or the bow region. Everywhere else, there's actually no lens epithelial cell production. It's just in this one area, the equatorial epithelial cells. Who develops cataracts? So almost everyone will develop cataracts. Typically, most people in their late 50s, and certainly the vast majority of people in their 70s will have developed visually significant cataracts. So let's talk about the basics of cataract surgery. Some of the symptoms. Many of you are aware, bright colors can become dull, halos around lights, difficulty reading in low light, frequent change in glasses. This is a common complaint. And increasing nearsightedness. As the cataract becomes larger in size, the lens itself becomes more powerful, rendering the eye more myopic or nearsighted. An old term for this is called second sight, where you didn't have to wear reading glasses ever, and now all of a sudden you're able to read without glasses. And that's a result of the cataract progressing. What are the treatment options? Continued observation. We do cataract surgery when it affects your lifestyle. If it's not affecting your lifestyle, we can watch the cataract. We don't have to do surgery right away. We can prescribe stronger glasses, and sometimes that's a viable option. And when neither of those is appropriate, cataract extraction with intraocular lens placement is the next step. Today's goals of cataract surgery are much different from 20, 30, 40 years ago, when the cataract was removed, the patient healed up, and then got a pair of glasses. That's the way it went. Today, the goal is to improve the quality of life of our cataract patients by increasing the chances of spectacle freedom with a quality range of vision. More people today are interested in getting rid of those glasses if they can. And this is the goal of the refractive cataract surgery that we do today. Looking at the eye, we can divide the front part of the eye, called the anterior segment, into its different segments. We can look at the cornea, which is like a watch crystal on a watch. Again, the major refractive surface of the eye is the cornea. The anterior chamber, which is this space here, and this is filled by aqueous humor. The iris, the pupil. Here is the lens, which becomes the cataract as we age. And then the zonules, which are fibers that are 360 degrees around the lens. They anchor the lens into this muscle called the ciliary body. This is the muscle that allows us to focus. It's a circular muscle behind the iris. The lens is divided into the anterior and posterior capsule. Again, the thin elastic membrane that's clear that surrounds the cataract. The cortex, which is the softer outer layer, and then the central nucleus, which is a little bit harder. Standard cataract surgery involves one, primary and secondary incisions. To access the cataract, we have to make a couple incisions in the cornea. Second is called the capsulorhexis. The capsulorhexis is opening that anterior capsule to be able to gain access to the cataract, much like taking the top of a circular portion of the onion skin off an onion to remove the onion inside. Lens fragmentation, we use a device called phacoemulsification, which uses ultrasonic vibration to emulsify the lens fragments and vacuum them out. And intraocular lens insertion through the primary incision. The laser can help in three of these steps. One, the primary secondary incisions. Two, creating the capsulorhexis. And three, the phacofragmentation, where we're actually dividing the lens into pieces, in this case into quadrants, or the laser can create circular segments to make removal of the lens much easier and safer in some regards. The incision. Accessing the lens requires incisions in the cornea and the anterior capsule. Here's the phacoemulsification handpiece entering through the main incision, and then secondary instruments are used through the smaller side port, as we call it, incision, to assist in removal of the cataract. The capsulorhexis, as it's called, is the way the capsule is opened when we do standard cataract surgery or do this manual. This is how it's been done for 50 years. So a small nick is made in the anterior capsule, which is very, very thin, and then a forceps is used to basically tear this capsule as round as possible. This is one of the most, if not the most critical step in cataract surgery. And when you're learning this as a resident, it's not easy. Every eye is different. You don't really have a feel for how this capsule reacts. And tearing this incorrectly and creating irregularities or having the capsulorhexis run outside of the central portion of the lens sets you up for complications. So it's really the most critical part of the surgery. Once the capsulorhexis is complete, the phaco handpiece is introduced, and fragmentation and removal of the cataract is then performed. The cataract, the capsular bag, as we call it, is maintained. The lens is then inserted in this capsular bag and is supported by the capsular bag. Most people have some astigmatism, some more than others. Astigmatism is an irregular shaped cornea. In other words, instead of the cornea being shaped like half a basketball, if it was stretched like a football, that's what astigmatism is. It's steeper in one axis and flatter in another axis. And that causes visual blur and requires glasses or contact lenses to correct for that. Surgically, we can correct for astigmatism by placing deep incisions, 85 to 90% depth incisions in the peripheral cornea. When they're placed in the periphery, these are called limbo-relaxing incisions. When they're brought in, they have more effect, and these are called astigmatic keratotomy incisions. We don't do these much anymore. These were done more during the days of radial keratotomy, but the limbo-relaxing incisions are very important. I used to make them with a diamond knife. It's kind of an art, being able to make those incisions as perfectly curved and deep as possible. The Femtosecond laser does a superior job, and we'll get into that. Let's talk about the basics of the Femtosecond laser. The laser creates incisions by photo disruption. Thousands of very, very short pulses are delivered to a very specific area. This is a computer-controlled system where the scanning system delivers each pulse very, very precisely to the exact spot. At the point of laser focus, a phenomenon called laser-induced optical breakdown occurs and forms a plasma bubble. This breaks the tissue and creates the beginning of an incision in the tissue. This is the LenSx laser system. This is the system that I use. It is a very good laser made by a company called Alcon. The delivery system is in the center here. This portion is a video microscope, and the user interface is used by the technician primarily. I have a live patient monitor, so once the cornea is docked to the laser, I have an overlay of where my incisions will be placed, where the arcuate incisions will be placed, where the Capsulorhexis will be performed, and I have the ability to be able to adjust any of those parameters at any time and move them as I need to. It also shows me an image of the anterior capsule and of the lens, cornea, the iris in live view. Typical patient flow really doesn't add that much more time. Patient comes in pre-op, gets prepped and dilated. They come into the LenSx laser room. The laser is done, maybe takes 4 or 5 minutes. The patient is then moved into the operating room where the cataract surgery is performed, and then back to recovery. And the maximum time between the laser and the operating room, I would say for me typically is around 15 minutes total, maybe a little less. So the future is here. Laser refractive cataract surgery assists the surgeon in some of the most delicate steps during the cataract procedure. And precise mitigation of the preoperative corneal astigmatism is unmatched compared to the manual limbo-relaxing incisions using a diamond knife that we used to do. And this is important for spectacle independence. For patients who want to get out of glasses, it's critical that we mitigate the astigmatism. Next slide is a little video.
With many technology advancements in cataract surgery, surgeons have options that allow patients to make informed decisions on how their cataracts will be removed. One such advancement is the LenSx laser. The LenSx laser is designed to bring advanced levels of accuracy and reproducibility to cataract surgery. By automating some of the most challenging steps of cataract surgery, the LenSx laser allows the surgeon to create precise, repeatable incisions using an image-guided laser. Cataract patients now have the following 2 options: standard cataract surgery or laser cataract surgery. Cataract surgery involves corneal incisions, Capsulorhexis, a circular hole in the capsular bag, lens fragmentation, phacoemulsification, intraocular lens insertion, and incision closure. The LenSx laser can assist with some of the most challenging steps. Standard cataract surgery starts with the creation of an incision through the cornea, utilizing a scalpel in order to allow the surgeon access to the cataract. The LenSx laser provides customizable laser precision and reproducibility in the creation of the incision. Capsulorhexis is the medical term used to describe the removal of the outer layer of the lens in order to allow the surgeon access to removing the cataract. This is the single most important step in your visual outcome. In standard cataract surgery, this step is performed by the surgeon manually creating a circular opening with a handheld instrument. The LenSx laser offers your surgeon laser precision to create the circular opening and allows the lens placed to have the best possible effective lens position. This allows you to experience the most predictable post-operative results. Standard cataract surgery requires a phacoemulsification machine to segment and remove the content of the cataract. The goal of your surgeon is to reduce the amount of energy used to remove your cataract. The LenSx laser performs lens fragmentation, creating easily dissected segments for efficient removal with little or no energy from the lens removal device. Reducing energy during the phacoemulsification step has been shown in studies to assist in healing and can be much less damaging than phaco energy during standard surgery. The LenSx laser offers enhanced levels of precision and reproducibility in cataract surgery.
So that, I think, is a nice little video to summarize the steps that we use in laser-assisted cataract surgery. And the results are phenomenal. I can tell you that they're exceptional. And I do a lot of laser, and I believe in it strongly. I think it's a great technology. So let's now skip a little bit to intraocular lenses. There are some different options. There are a lot of lenses. Surgeons use different lenses depending on their preferences. The lenses are really divided into 4 categories: monofocal, toric, a multifocal, or EDOF, EDOF standing for extended depth of focus, and then accommodating lenses. Monofocal intraocular lens, this is the basic lens that has been used since Harold Ridley's original invention. They've, of course, advanced in technology. They've gotten much, much better. They're excellent. The optical qualities are fantastic, with excellent optical quality. The refractive options that are available with a monofocal or a standard type lens are you can have distance vision. You could choose to have near vision. If you're nearsighted and you want to stay nearsighted, we can do that. Or in some cases, with a standard lens, we can do monovision. One eye, the dominant eye typically, is set for distance, the non-dominant eye for near. And that affords the patient the ability to get away from having to wear reading glasses all the time. Now, not everyone can handle that. So I like to see patients who have done that in contact lenses, and we know that their brain can neuroadapt to that they're used to it, and then that's a great option for them. For most people, monovision may not be the best choice. Of the lenses that are out there, the monofocal varieties, the lens that I use primarily, I've used this lens for years by Johnson & Johnson, and I have no affiliation with any of these companies, by the way, is the Tecnis IOL. I think it's an excellent lens. It has low chromatic aberration, meaning that the wavelength of various colors of light are focused very precisely on the retina. It has low surface reflectance, full transmission of blue light. Competitor Alcon lens has a yellow chromophore, a little bit of a yellow tint to it, which blocks blue light, wavelength of light, and I think blue wavelength has been shown in many studies to be actually important to us. And it has really no glistenings for the most part, and I'll show you what glistenings are. The image on the left is an Alcon lens. These are, if you can, it may be hard to see, but there are very, very fine little dots within the substance of this acrylic material, and these tend to get worse over time. These are collections of small amounts of water within the material itself, and it can be visually significant. When they're mild, they're not, but if they progress and become more severe, they certainly can be. The Tecnis lens is nice and clear and really does not show these glistenings over time. Toric lenses are lenses that correct for higher levels of astigmatism. Lower levels of astigmatism we can correct with a laser, sometimes manually if we need to. But when we have patients who have higher levels of astigmatism, we move to a toric lens. You may not be able to see it. This lens has 4 little dots here and here. This is the axis of the astigmatism. So this is how we align this lens in the eye. Once we implant the lens in the eye, we rotate it to line it up with the corneal astigmatism, and it can correct that fully. It's a great product, and the results are fantastic. And it's very rotationally stable, so it tends not to move over the years. Multifocal lenses are in the premium lens category, as we call it. These are designed with a series of visual zones that provide a range of vision. And the image quality can be excellent at all ranges. They can be associated with halos at night. Some of the lenses are more prone to that than others. The lens that I use primarily is the Johnson & Johnson Symphony, and I haven't had a lot of halo issues with my patients. It's been a very good lens, and it really has not been an issue. Alcon makes a Restore lens, has been around for a long time. I do not use the Restore. Alcon has just released a new lens called Panoptix. This is what's called a trifocal lens. I don't have experience with it. I hear it's a very good lens, but the Symphony has these rings, or what are called echelettes, that are lathed into the posterior or the back surface of the lens. When light comes into the lens, it is bent in a way that it elongates the focal length. So unlike other prior what are called multifocal lenses, where there are actually 2 focal points, a distance focal point and a near focal point, this EDOF technology, or extended depth of focus, broadens the depth of focus and gives, I think, sharper vision. And patients adapt to this lens, in my experience, very, very quickly. Accommodating lenses. Bausch & Lomb makes the only accommodating lens in the United States. I put this in quotation marks because an accommodating lens has to move in the eye when we focus from a distant object to a near object. And there are a number of studies that show that the crystal lens may not do this. These are called haptics. This is a plate-style haptic. This is the optic of the lens. And these haptics, there's a little line here. This is a hinge. And this is supposed to allow this lens to flex forward and backward during focusing from distance to near. I believe that the capsular bag scars and that this lens doesn't really move much at all. But it's a good lens. It provides good distance vision, no potential for halos and glare. It doesn't have the rings in the optic. The intermediate vision is very good. Near vision is going to typically require low power reading glasses. So it's not strong enough to give you good near vision without glasses. So a lot of patients ask me after they have cataract surgery, will this come back? Will I ever have to have this redone? And my answer is no, the lens has been removed. We have a new intraocular lens in the eye. It never has to be replaced. However, one thing that can happen is something called posterior capsule opacification. So in 20 to 25% of patients, typically a couple months to a couple years after surgery, lens epithelial cells, again, if we remember that anatomy I showed you in the beginning where that equatorial region of the lens which produces these lens epithelial cells, those cells are stimulated after cataract surgery, and they sometimes will migrate and proliferate. And when they do so behind the lens, the capsule, which is normally clear like saran wrap, will opacify. And this is an old term for this is secondary cataract. And symptoms include visual blurring and glare, just like having the cataract again. And this is caused by lens epithelial cell migration from the periphery of the capsular bag behind the lens. We can't see that region of the capsular bag when we do surgery. It's behind the iris, and we can't remove every single residual lens epithelial cell. So 20-25% of patients, this occurs. How do we fix this? So the solution is a pretty straightforward operation, a laser called YAG laser capsulotomy. This is what the laser looks like. You come into the surgery center, we dilate your eye, you sit down at the laser. It takes about a minute to clear this up with the laser. It's safe, it's effective, and it is covered by insurance. All right, so that ends the first portion of this lecture, and I wanted to move on to some of the research that I've been involved with for about 12 years. Let's see. Okay. All right. So it was back in 2008 I started thinking about this posterior capsule opacification problem. The volume of surgery I was doing, close to 1,000 cataract surgeries a year. On any given week I'd be doing 10, 12, sometimes more YAG laser capsulotomy. I started thinking, well, you know, why do patients have to go through this? There must be we know what causes it. Why can't we stop this and maybe reduce this from 25% to 1 or 2%? This actually costs Medicare about $350 million a year currently, YAG laser capsulotomy in this country. So I started thinking about different ways to protect the lens, to create more of a mechanical barrier so that these cells could not migrate behind the lens. I co-founded a company called Clearsight in 2013. Charlotte is a startup out at the biotech campus at the Colorado Anschutz Medical Center. And I found out about this company, was very intrigued by their technology, and called them up, and we got together, did some work together, and then co-founded this company, Clearsight, in 2013. I invented this intraocular lens, and we call this the Clearsight IOL. This is the implant here. The optic is centrally located, but in the periphery we've added a bit of a skirt, if you will, a thin membrane as we call it. And these are what are called haptics that center the lens behind the pupil. And my thinking was that if we could create a mechanical barrier for lens epithelial cells coming in from the periphery of the lens, they would have a much harder time being able to get all the way back behind the lens. We have a patented material. This is a hydrophobic material called nanohybrid. This lens will go through a small incision, very controlled unfolding. It has all the properties that are typical in acrylic lenses that we use today. It demonstrated no evidence of glistening, and we did a study at the University of Utah with Liliana Werner, who's an expert on this PCO problem, and proven biocompatibility in the rabbit model. So a little bit about this company, Charlotte. So Anthony Brennan, who was a chemical engineer at the University of Florida, came up with this idea that, you know, why is it that sharks have very clean skin, they don't have barnacles or anything on them, and it's a relatively slow-moving animal in the water, whereas turtles and whales collect all this stuff. And his interest in this was he was working on anti-fouling for ship hulls with a naval grant that he had received. And he came up with this idea that, you know, let's look at a shark skin and see if it has any features that might attribute to this characteristic. This is a close-up of what are called denticles. They're not actually scales. They call these denticles. And you can see it's this sort of diamond-shaped periodicity with these horizontal lines in each diamond. And so he came up with this idea that we could match this micro pattern and we could scale this down. Perhaps this would inhibit algae adhesion and maybe bacterial adhesion as well. And he started the company Charlotte. They moved to the biotech campus at the university in Denver, and the rest is history. They have a number of products: endotracheal tubes, Foley catheters, cell phone covers, lots of different things. Very, very interesting technology. Not using any chemicals, just using biomimicry, just mimicking what's found in nature to come up with something that works efficiently. This is an example, this is a picture actually of the Clearsight IOL. This is the optic, this is the membrane. We've added the Charlotte micro pattern to this outer membrane on the back surface, on the posterior surface. And this has been shown to reduce the PCO. It in fact worked. It inhibited the lens epithelial cell migration. In this model on a bench study, these are cultured human lens epithelial cells, and they are blocked by this border. We published a couple of papers. This is a paper that was published in the Journal of Cataract and Refractive Surgery recently. We did this at the University of Utah. This is done in rabbits, and rabbit eyes have a very enhanced reaction to an IOL, and they become quite inflamed, and usually by week 1, week 2, they start to develop posterior capsular opacification, or PCO. So at 4 weeks, this is a control lens. This is the Acrosoft lens by Alcon. And this is what's typically seen at 4 weeks in the rabbit eye for most of the lenses that we currently use today. And this is the ClearSight IOL. These are slit lamp examinations, the instrument that we use to examine your eyes. And you can see that the posterior capsule is crystal clear at 4 weeks. These are what are called Miyake apple views of the rabbit eye. So this is the eye post-mortem. You're looking from the back side, as if you're looking from the back of the eye through the pupil. And this is the Acrosoft lens. You can see the fibrosis that has occurred in 4 weeks. And this is the ClearSight IOL, which remains very clear at that 4-week time point. So this lens, it has what's called an open bag design, and I won't get into those details, but it has features which keep that capsular bag open so that it doesn't collapse during the postoperative healing period. And this has been also another way this has been proven to inhibit the migration of lens epithelial cells and PCO. So it reduces PCO and ACO, anterior chamber opacification, or anterior capsule, opacification. The lens shows excellent centration in the capsular bag, and it's manufactured using the same standard industry methods. This is a table from our paper that shows the results of the PCO. This is the Acrosoft lens score, 3, with the Sharklet ClearSight IOL with the Sharklet micro pattern. You can see that the PCO is much reduced. And when we tested the PCIOL, or the ClearSight IOL without the pattern at all, we still saw a significant decrease in PCO in the rabbit model based on that skirt, that outer mechanical barrier. It's just better with the Sharklet pattern. So ClearSight, we have a number of different things going on, but 2 very exciting collaborations. We are working with a Dr. Ruit. He's a famous ophthalmologist in Kathmandu, Nepal. This is the Tilganga Eye Hospital. It's one of the biggest hospitals in Nepal and northern India. And Dr. Ruit has developed an intraocular lens lab where they actually make about 400 lenses a year. 400,000 lenses a year. And so they're very interested in this ClearSight IOL. Developing countries don't have access necessarily to the laser that we do. In the US, it's pretty easy to make an appointment to get scheduled for a YAG capsulotomy. It's done and insurance covers it. But in developing countries, patients can go blind from this PCO. They don't have access to a laser. It's not easy for them to get to one of these large hospitals often. And culturally, many of them feel that maybe the surgery worked for a while and now it doesn't work, and they just don't come in for a laser. So if we could reduce that from 25% to 1 or 2%, that would be a huge benefit to the patients in developing countries who have cataract surgery. We're also starting a clinical trial, a human clinical trial, with the Aravind Eye Hospital in India, in northern India. They're one of the largest hospitals in all of India, a tremendous place. And they're interested also for the same reason, having an implant that does not require a YAG laser capsulotomy. So we're looking at working with them and developing a study protocol for about 100 patients. Very excited about that. This is me and my team in Kathmandu at the Fred Hollows IOL lab, and this is where the IOLs are manufactured. And you have to be in a clean room and a clean suit, which I can tell you is very hot. I don't know how these people do it all day long, but they're all very, very nice people. And finally, we have a lens that we're also very excited about, a different arm. We've been funded, the Clearsight IOL, on NIH grants, which has been very, very fortunate for us. We have now secured a phase 2 NSF grant for our accommodating lens. So we are working on an implant, a very novel technology that uses the eye's natural accommodation mechanism to focus from distance to near. And the way that occurs in the eye, and I've included a couple pictures here to show that the lens is relatively flat in the unaccommodated state when you're looking at a distant object. But when you focus it near, at least when you're young, before 40 or so, the lens is soft enough and it's able to round up, which makes the lens more powerful, focusing those light rays on the retina. So the lenses that I've showed you today, all of the lenses that we use currently are static, other than crystal lens, which may move a little bit, may not, but they're static pieces of plastic. This is a lens that could change shape and create a significant amount of accommodation. And finally, just to end with a slide of Dr. Ruit, these are some of his postoperative, one-day postoperative patients in Nepal. This would be 1 day of surgery for him, and this could be anywhere in Nepal. He travels all over. He's quite a wonderful man. So thank you very much. I hope that's helpful in understanding cataracts and cataract surgery. If you have any questions, I'm happy to answer any of your questions today.
We do have quite a few questions. I will start with this one, which is, will I be safe if I come into your office?
I'm sorry, could you repeat that?
Will I be safe if I come into your office?
Obviously, with COVID, all of us are doing things quite differently. Our office was closed for almost 2 months, and we were unable to see patients other than sight-threatening emergencies. And of course, elective surgery was closed down for 2 months. We had a lot of time to put protocols in place and to think about how we were going to change the way we see patients in our office. And we have a number of, we have a very strict, actually, protocol as to how patients are seen. Rooms are cleaned extensively between every patient. Rooms are aired out between each patient. Patients do virtual check-in. We don't have a waiting room full of patients anymore. We have patients that call or get a text on their phone, wait outside one of our 2 entrances, and then are brought in, temperature is checked. And so we have all these protocols in place. I'd say it's working very well. Patients are required to wear masks. We wear masks, of course. It's actually, I think, a very safe environment.
Thank you. A viewer asked, if you are dissatisfied with the results of a cataract surgery, can it be repeated using different technology?
To answer that question, the answer is, so if you were dissatisfied with the results immediately after cataract surgery, and that would be something that doesn't happen often at all. We have the best technology available to get the measurements that we need to calculate the right power of implant to put in your eye. But if for some reason that power was off, maybe you had prior LASIK or PRK, and you were unhappy, we can do an IOL exchange. So I'll take you back to the operating room, if that's done within 4 to 6 weeks before it has time for those haptics to scar into place. I can remove that lens and put a new lens, and that works very, very well. Long term, if you're not happy with it and you want a different technology, it's not going to happen because the lens is scarred into place and the risks far outweigh the benefits.
That kind of piggybacks on the next question, which is, I've had PRK surgery. Will I be able to have cataract surgery?
Oh, absolutely. So PRK and LASIK create a challenge to surgery only in that the refractive corneal surface, the refractive power of the corneal surface has been altered by the laser. In most cases, patients are very nearsighted. They have LASIK to correct that nearsightedness. which means the laser is flattening the cornea. The way our measurements work, our formulas are based on corneal curvature, which translates into corneal power. And so the mathematical formulas have to adjust for PRK or LASIK. We have a number of newer formulas that we use now that are very, very accurate. And so we're pretty much right on most of the time. Every once in a while we have somebody that's off, and we can do IOL exchange if we absolutely have to.
Okay. Does wet macular degeneration make cataract surgery more difficult?
No. Wet macular degeneration, obviously macular degeneration is a big thing in elderly patients, and we have no, it doesn't affect the surgery at all in any way.
Okay. This is a recurring question. A lot of people are asking this one. Is the patient awake during surgery, and what kind of anesthesia is used?
Right, so when you come into the surgery center, and we've just opened our new surgery center, Premier Eye Surgery Center over in Lafayette. Really nice, state-of-the-art. We're following all the CDC protocols, so very, very safe. We're operating at a slower pace than typical right now, and we'll ramp up as we can. But you'll come into the surgery center, you'll have an IV placed, the nurses will dilate your eye, all the paperwork is done. Anesthesia will give a little bit of Versed and fentanyl typically. So this is very light sedation. You're awake during the surgery. We want you to be awake because we may ask you to move your eye or focus on the light if you're drifting away. We don't want you to be completely out. But because of the Versed, you may not remember all the details the next day.
Does cataract surgery correct floaters, and would it help with night driving?
It does not correct floaters. So floaters are in the vitreous, which is behind the lens, the capsular bag, behind where we're working. And what I can tell you is that in some cases, the floaters get better because just the surgery alone changes some of the spacing in the eye, putting a thinner lens in the eye as opposed to a thicker cataract. And sometimes the floaters will move out of the way or not be as noticeable. Sometimes they're still there. Sometimes they're more noticeable. But there's nothing that we can do to remove the floaters at that time.
Oh, can you address night driving issues and how cataract surgery may or may not help with that?
Night driving issues with the cataract or after cataract surgery?
Yeah, would that improve? I think
Absolutely.
the question is, would it improve with cataract surgery?
Well, one of the leading symptoms that I see every day in clinic is difficulty driving at night. And one of the main reasons for that is the type of cataract that patients get. So there's different types of cataracts. Opacities on the front of the lens are called cortical changes. And those tend to be visually insignificant for the most part. The age-related change that happens to all of us as we get older is called nuclear sclerosis. And that's where the lens goes from clear to yellow-brown, to coffee-colored if you wait long enough, if it's a ripe, in the old days, cataract. The type of cataract that we see very, very commonly here in Colorado, perhaps because of the altitude and exposure to ultraviolet radiation and not wearing sunglasses and other things, people who are outdoors a lot, which is most people in Boulder, is what happens on the back of the lens. This is called a PSC, or posterior subcapsular cataract. This type of cataract tends to scatter a lot of light. And because of its position in the lens and the optics of the eye, it causes much more problems with vision, particularly at night. And glare and halo, very common.
Okay, next question. Are all lens options and post-operative procedures covered by Medicare?
It's a very good question. So no. So the answer, Medicare will cover standard cataract surgery. And what's meant by standard cataract surgery is the manual approach, the way it's been done for 50 years, where I'm doing it by hand using little scalpels to create the incisions, opening that capsule as you saw with a forceps manually, and then putting the lens in. It won't address astigmatism, so most patients, you have to anticipate that you're going to need glasses or contact lenses when we're done, for distance and for near, both. The premium lens options, so let me back up. If you opt for the laser, that adds our practice, we charge $1,550 per eye. Insurance will not pay for the laser, unfortunately. If you opt for a symphony or a crystal lens, or one of the premium lens options, that adds more. These companies are charging more for the lens. It's an upgrade, and so those prices increase the cost of surgery. And those are out-of-pocket expenses. The insurance companies don't cover that.
Okay. Okay, so these are two questions that are fairly related. Let's see. The shark lens that you discussed.
Yes.
And the last accommodating lens that you discussed.
Yes.
Are they still under development, or are they ready to use now?
Oh no, they're far from being ready to. I did not show a picture, as I really shouldn't be showing a picture of the accommodating lens. They're in development right now. The ClearSight lens is done. We have that lens made. It's easy to manufacture. And we're working with these two companies in Nepal and in India. We'll ramp up manufacturing of these lenses to do these studies. They are not available at this time. They're not CE approved. They're not FDA approved. The accommodating lens that we're working on, we feel that we will be able to put that in human eyes within the next 1.5 to 2 years, a small number of patients, and then we go from there. But it's a long process. It takes a long time.
Okay. Are there studies on who would benefit from crystallines and who would not?
I'm not aware of studies that we make the decision as to which lens is best for each patient based on a number of different factors. A lot of it depends on the health of the retina, macular degeneration, diabetic retinopathy, other retinal issues. Maybe not such a good candidate for one lens versus the other. Personality type A personality may not be the best person that might notice every little thing with a multifocal lens, for example. Maybe they'd be better off with a monofocal lens, or maybe they'd be better off with a crystal lens. So the decision as to which lens to use is based on a lot of different factors, what the refractive outcome is going to be and that sort of thing.
Okay. And with cataract surgery, do you do one eye at a time or both at once?
One eye at a time. This is how it's done, has been done traditionally. I do the eyes 2 weeks apart. I like to wait between eyes 2 weeks. Risk of infection, which is exquisitely rare, tends to happen a couple days after surgery to maybe 10 or 12 days after surgery. So I like to be sure that the patient is out of that period, that the eye's doing well, the first eye's doing well before we move on to the second.
Can cataracts come back?
Only this secondary cataract or PCO that I described, posterior capsule opacification. So that is what can come back. The actual cataract itself cannot come back. The lens is gone. The patient has a piece of plastic in the eye at this point. Okay. Acrylic.
One of our viewers would like to know, do you take Kaiser insurance at all?
That's always a tricky one. No, I'm not a Kaiser physician, so I do not take Kaiser insurance.
Okay. Is there a solution to resolve negative dystopia? I'm not sure if I'm saying that right.
There is.
Dysphototopia?
Right.
That can happen after surgery.
Yeah, very interesting question. That's so negative dysphotopsia. There are two types of dysphotopsia. These are artifacts that are seen, light abnormalities that are seen after cataract surgery. Positive dysphotopsia is by far the most common. Positive dysphotopsia is a ring or edge glare, where patients might see if their pupil is large enough, like in low light conditions, they might see the edge of the lens and they might notice a little arc of light. That's by far more common than negative dysphotopsia. Negative dysphotopsia is a dark crescent that is seen in someone's vision. It doesn't seem to go away. And we don't quite understand what that is, what causes negative dysphotopsia. But the way to treat that is to do an IOL exchange, to take that particular lens out and to put another lens in. And if it's been several years since the surgery, that may or may not be a good idea. Or sometimes a piggyback lens can be put. So another very low power lens can be placed in front of the lens, and that will take care of the problem. But again, it's an exquisitely rare problem. I've only seen negative dysphotopsia in my 20 plus years of practice, maybe 2 or 3 times.
So next question is, does the surgery help with presbyopia?
Presbyopia, yeah. So presbyopia is the inability to focus at near that happens to all of us, starting at anywhere from age 40, 42, somewhere in there. Our arms become longer, and then we need to have some help. So we start with low power readers, and as we get older, we need higher power readers. A monofocal lens won't address presbyopia. You can have, if you think back to the earlier slide, you can have either distance vision or you could have near vision. You can't have both with a monofocal lens, unless you were going to do monovision, and that's not for everyone. So we would look into the premium lens option, which would be Symphony, which would be a great lens, or possibly Crystal Lens, to give the patient the ability to have some near and intermediate, and that would correct presbyopia.
Thank you. What are the post-surgery restrictions?
I'm sorry?
What are the post-surgery restrictions?
Post-surgery restrictions. Oh, very good question. Every surgeon is different in their restrictions. I'm pretty lax. So for me, I think that you have to take it easy for the first week or so. Nothing extremely strenuous. I tell patients, nothing that's going to get you red in the face. I don't want you lifting super heavy objects. You're not going to be moving any refrigerators or, doing a marathon right after surgery. That's not a good idea. But light exercise, cycling is fine. The one thing that I think as a cornea specialist, I'm always very careful about is contaminated water sources. So for me, no pools or hot tubs or lakes, ponds for about 3 weeks. The incision that we make, the 2 incisions in the cornea, are very small. There's no suture required. But the last thing I want to see is a patient come back where they have acanthamoeba, which is a parasite in contaminated water sources that can get in through that incision, and that's a very difficult thing to treat. But other than that, they can, bending is fine, can lift light objects. Anything you can lift with one arm, I think is reasonable. So really minimal restrictions. You can drive as soon as you feel comfortable, usually the next day.
What happens if you are allergic to the medication that's normally put into the eye pre-surgery? Are there alternatives that can be used?
Yeah, there are. So preoperatively, we start patients on an eye drop, what we call a triple drop. We now have a pharmacist that compounds these medications into one drop. It's less expensive for the patient. It's a lot easier for the patient than using 3 different drops. And the drops that we use are an antibiotic, of course, a steroid, and a non-steroidal anti-inflammatory. And I'll start those drops 2 days prior to surgery, and then they'll be on those drops for about 3 or 4 weeks after surgery. If someone is allergic to one of the antibiotic, for example, then we'll choose a different antibiotic. So we have lots of different options that we can choose from.
Okay, thank you.
Yeah.
I think we'll make this the last question.
Okay.
And a viewer wants to know how many people are not happy with the outcome of a cataract surgery?
In my experience, I would say it's very uncommon. Probably maybe less than 2%, I think, if I had to guess. I think a lot of time is spent in pre-op. You know, I'm a surgeon who wants to really understand the patient's needs. I want to make sure that we choose the appropriate lens for their lifestyle, and I want to be able to meet their expectations, and that takes some time to figure out. So we're going to have that discussion in clinic, and it may take a little bit of time to get there. I think if I do a good job doing that on the front end, it really is going to reduce significantly, this is how I've always felt, those patients who are unhappy after cataract surgery. It does happen sometimes. Sometimes it's personality, sometimes the lens power was off, and we can work to fix those issues. But it's very, very, very uncommon. Yeah.
Well, thank you. We've come to the end of our time. Is there anything else you'd like to address?
No, I just want to thank everybody.
Know?
This is obviously a different time for all of us, but I appreciate your taking a little bit of time out of your evening tonight and watching this presentation. Means a lot to me, and I hope you got a lot of good information from it. So,
thank you, Dr. Cuevas.
thank you.
A recording of tonight's lecture will be available at bch.org/livestream. You will receive a post-lecture survey by email tomorrow, and we ask that you do please take a minute to fill this out. Thanks again, and have a wonderful evening.
Thank you.